Dr. Gutierrez. How are you today?
Doing good. Thanks for having me.
Good. I'm excited to just get to sit down and talk to you and ask you about some of the questions we get from patients in clinic and just some of the hot topics in pain management. So
Let's do it.
I thought maybe we could just start, and can you just tell people a little bit about who you are and your background?
Jerry Gutierrez, as you said. I work at Pain Specialists of America at the South Austin Clinic and also in Round Rock. I'm an interventional pain physician primarily focused on minimally invasive procedures and such to treat chronic pain.
Awesome. Well, so I guess my first question is, what do you think about spine surgery? Should patients try to avoid spine surgery?
No. I think we can all agree it probably shouldn't be the first thing we try, outside of like a trauma situation. But oftentimes, there's a certain situation where we need to decompress a patient or stabilize instability. And I know a lot of patients that come in and they're like, I was told to never have spine surgery, I should never have spine surgery, but at the same time they can't move their leg. So, it's kind of, your other option is just letting this get worse or staying the same. So I'll be the first to say spine surgery changed my life. I mean, I tried all the stuff that we offer, injection after injection, physical therapy, acupuncture, all the non-surgical things. At the end of the day, the spine surgery is what I needed. And I think it's my role and my duty to let a patient kind of graduate to that if what we try isn't helpful. And a lot of times we can offer really productive and really effective treatments, but sometimes they do just need to get something stabilized or decompressed.
Yeah. That's really awesome to be able to have a first-hand account too, like that, to share with patients.
They're surprised to hear that about me, and then they kind of know that I've been in their shoes before, and that helps too.
So one of the things that we try one of the first steps we try when patients come in before you would ever send them to surgery are epidural steroid injections. So patients have questions about that. Are they bad? How many can they have? Can you talk on that for a minute?
Well, very patient and condition specific. For an acute herniated disc in a 25-year-old, they're not bad. But in spinal stenosis in an 85-year-old, maybe we need to limit them a little bit because the medication, which is the steroid, can have side effects, especially in an older person that's more frail. It can lead to hypertension, irregular heartbeat, weight gain, water retention, just to name a few. So I usually limit the doses of steroids, but I can do a few on the younger folks, but I try to limit them and maybe try a non-steroid or non-medication modality in my older folks.
Okay, so that's why you tell people, maybe 3 to 4 per year?
On the young, healthy ones,
right.
Yes. But again, like an 85-year-old, I might do one.
Mm-hmm. I see.
Yeah.
Okay. Kind of to switch gears a little bit, I think a lot of us have seen these new sensational series coming out on Netflix and Hulu about the opioid crisis.
Right.
Where are we with that, and what are we doing about that?
I think things are starting to get better. I know maybe 10, 15 years ago things were pretty grim, but I think we're getting better with that. Sometimes opioids are necessary at low doses and for short courses, but I think we're getting away from the high dose chronic prescribing as a primary modality. We have a lot of more cutting edge, minimally invasive treatments for chronic pain. And oftentimes we can get around even using those medications at all. I said earlier that they're sometimes necessary, but I am a firm believer that the longer you're on a medication like that, especially at high dose, you're going to start getting tolerance and physiologic dependence that it's actually becomes the condition or a condition in and of itself.
Right. So to kind of go off of that, like you said, we have other things that we can offer. One of the technologies that I know that you do a lot of is the peripheral stimulator.
Yes.
It's kind of a mouthful. Can you tell people what that is?
Peripheral nerve stim, or PNS, I'm a huge proponent of and believer in. I think it's really useful in patients that have focal pain. And it's really helpful for neuropathic pain. So there's very many kinds of stimulators, from deep brain to cortical brain stimulators, and then the most popular one you hear a lot about is spinal cord stimulation. Sometimes there's a focal area that those stimulators cannot quite capture. And a lot of times patients aren't candidates for those other more invasive kinds because of comorbidities or anatomical barriers with, spinal conditions, or they're on blood thinners, and it's not a good idea to introduce, something into their spine like that. So a lot of times we can avoid that risk by targeting, a nerve out in the extremities, out in the periphery, whether it's the occipital nerve in the head or the saphenous nerve in the knee for chronic nerve pain after a knee trauma, fracture, or knee replacement. We can avoid a lot of those risks with, placing an electrode in the spine and stuff like that. So, again, I think it's a very cool therapy, and I've had a lot of success with it in the last few years.
That's pretty amazing. Now, what about headaches? Is that something you can do for headaches, or what are you doing to help people with treatment-resistant headaches who have failed things with their primary care provider and come to you and say, help, I'm not getting any better with these things?
So there's a lot of different things we can do. If it's a migraine or if it's we call a cervicogenic headache, a lot of times people come to me having tried all sorts of medications for migraine, and sometimes they do have true migraines, and we can do something like an occipital nerve stimulator, which we know has connections to the innervation of the meninges and stuff. So we can actually help migraine with occipital nerve blocks and ultimately occipital nerve stim. Other things we can do is addressing cervicogenic headaches. A lot of times people have arthritis in their upper neck that causes pain in the back of their head, and something that very closely mimics a migraine. With diagnostic imaging, flexion extension films and such, we can sometimes uncover the source of the headaches as upper neck arthropathy, and we can do something like high occipital nerve or facet joint blocks and ablations to help those headaches.
That's so cool, and I like your point too. It sounds like you're really trying to get to the source of the headache rather than kind of just treating it with, maybe let's try all these different medications and see if it makes it go away. Sounds like you're really trying to work hard to figure out, like, where is this headache coming from and what part of your anatomy is maybe causing it.
Exactly, yeah. That's kind of my method and my workup.
Right, that's great. Okay, well, what about on the prevention side of stuff? Is there a good way, like, what do you tell maybe some of your younger patients what they can do to help prevent their spine maybe from getting bad later on?
Yeah, so we all kind of reach peak spine health, in our early 20s, and kind of the joke is it's all downhill from there. But there's a lot of things you can do to kind of slow that down and protect yourself. I think keep moving. Don't just sit around. Our backs weren't really designed to sit in chairs all day, so sit-stand desks are great. Also, when you work out or when you do any kind of exercise, don't forget to work out your back. Stretching your back, keeping those muscles moving is important, and core strength is important too for a lot of reasons.
Yeah. So, on different podcasts and with a lot of sports people, I hear a lot of chatter about stem cells.
Right.
And I have patients ask me about stem cells and regenerative medicine. So I was just hoping you could maybe touch on that a little bit.
So I do offer that treatment for certain issues. We offer PRP, we offer bone marrow aspirate concentrate, and we also offer intradiscal therapies and injections. The hard thing about stem cells is the evidence. A lot of patients have stories and athletes have stories about working anecdotally, and so do I. I have anecdotal stories of patients I injected and it got better. We like to be systematic and evidence-based, and with the evidence surrounding regenerative medicine or stem cells, the studies are really inconsistent in terms of standardization of what was used. So whenever you study a medication or a treatment, you want to standardize, what was given, what volume, how it was harvested, and none of that is really consistent on all of the stem cell studies I've read. There are some small cohort or small population studies using PRP in like tendon tears and especially partial thickness tendon tears that look positive. And I do offer it in certain like post-traumatic or sports injury situations.
What's PRP?
What is PRP? That was one of the first things you said.
Right, so PRP stands for platelet-rich plasma. So what we do is we draw blood from the patient and spin it down to harvest the plasma that's rich in platelets. If you took high school science, the platelets plug the bleed. But they also help promote healing. They signal a ton of growth factors that rush to the area and start rebuilding the callus or the wall to heal that injury or that bleed. So by injecting PRP, we're able to insert a lot of growth factors and signaling molecules into that area.
Okay. So my last question is, a lot of patients want to know about spinal cord stimulators. It's a pretty popular therapy. What has been your experience with those?
So I'm a big believer in that therapy, and there's been a lot of advancements in the last 10 years regarding that therapy and how it's delivered, both from the actual hardware, it being MRI compatible, it being rechargeable or non-rechargeable, the batteries are getting a lot smaller, but also the actual therapy that's delivered is a lot different than it was 10 years ago. So a lot of times patients have an experience from 2008, 2009 that was really bad or is really not helpful, and I try to encourage them to maybe try it again because things have gotten a lot better. The way I approach it with my patients is I tell them, this helps a lot of people, but it doesn't help everybody. It helps patients with neuropathic pain, and it helps people with post-operative neuropathic back pain. So the best thing about it is they get to try it before they really commit to it. It's the only surgery I really know of where you get to really see the result before you jump into it. Most surgeries out there, it's kind of a leap of faith. You think, this is going to help my knee pain, help my back pain, and you just have to see what the outcome is afterwards. With SCS or spinal cord stimulation, you get to actually try it for about a week and see exactly what it's going to do to you and your chronic pain before you decide to commit to it or not.
Yeah, and I totally agree with what you said. I think it's just so important picking the right candidate, picking that right patient that the therapy is going to be correct for. So people are really trying to boost their health these days, and one of the ways that we're trying to do that is through different supplements. But you can get them anywhere. You can get them in the grocery store, you can buy them on TV, they're advertised. What is your advice to your patients about supplements?
Well, there are some good supplements out there that we know modulate or reduce inflammation. The hardest thing, though, about supplements is really figuring out where you're getting them from. I'm not an expert on the topic by any means, but I do know that by and large, supplements aren't FDA regulated. So sometimes you don't really know what you're getting. So although there are good supplements like arnica and stuff like that that do help inflammation and subsequently pain, it's really important to pay attention that you're getting them from like a reputable supplier.
Well, this was really, really helpful. I think these are really popular questions,
Well, thanks for
and
having me.
people
That was really
will
good.
be really happy to get these answers. So thanks for your time, and I'll see you back in clinic.
Sounds good. See you all Monday.